Thank you, Dr. Oak.
Thank you. Press examination. Ms. Schneider, ready? Sure, of course, absolutely.
Good morning, ladies and gentlemen. Good morning, Dr. Ozer.
Good morning.
It's nice to see you again.
Likewise.
We met at your deposition earlier this year, but again, my name is Bethany Schneider. I represent R.J. Reynolds in this case. Okay?
Okay.
And I'm going to be asking you a few questions about some of the things you discussed on direct examination, all right? One thing you did discuss discussed was the fact that you're a medical oncologist, right?
Right.
Now, you discussed that you're board certified in internal medicine, but you're not board certified in oncology, correct?
That's correct.
And you said that your areas of personal interest are leukemia, lymphoma, myeloma, and GI malignancies, right?
Right.
Not lung cancer.
Correct.
You did mention that you have some familiarity with breast cancer, right?
Right.
And you've done some studies related to treatments for breast cancer, correct?
I've published in both lung and breast cancer.
You've never published any peer-reviewed literature on the diagnosis of lung cancer, correct?
That's correct.
Now, you're here as a retained witness, right?
Yes.
You did not treat Mrs. Adamson, correct?
Correct.
You've not spoken to any of Mrs. Adamson's family members.
Correct.
You've not spoken to any of Mrs. Adamson's treating doctors.
That's correct.
You don't know Dr. Daniel Spitz, correct?
That's correct.
And you asked plaintiff's counsel if they had talked to Mrs. Adamson's treating doctors, and the answer was no, right?
That's right.
So I want to ask you some general questions about diagnosing cancer before we talk about Mrs. Adamson specifically, okay?
Okay.
Primary cancer refers to where a cancer starts, right?
That's correct. The organ in which it starts.
And metastatic cancer is cancer that has spread from the place it started to another place, right?
That's correct.
Just because there's cancer in the lung does not mean it's a primary lung cancer, right?
That is correct.
Now, cancer can start almost anywhere in the body and spread to the lung, correct?
Yes.
And cancer metastasizing to the lung is actually a very common occurrence,
Yes,
correct?
it is.
You've seen cancer metastasize to the lung countless times in your career.
Yes, I have.
And the lung is actually one of the top places for cancer to metastasize to, right?
Yes.
In general, it's more common for tumors in the lung to be metastatic than primary, right?
It depends on the particular type of cancer, but in general, that's yes.
And although typically a single tumor in the lung is primary, sometimes metastases to the lung can also appear as a single tumor.
That's correct. So if there's a single mass in the lung, that is typically lung cancer, but you can get an isolated mass as a metastasis.
And I think you said on direct examination that a single tumor in the lung can sometimes be from breast cancer.
Yes, it can.
And just because you have a big tumor somewhere else doesn't mean that there's not a primary tumor in another organ, correct?
I'm sorry, I don't understand that question.
Sure. Just because you have a big tumor, a large tumor in one place in the body doesn't mean that that's necessarily the primary.
Oh, yes, that's correct.
Even when a primary is small, it can still cause a lot of metastases throughout the body, including the lung.
Yes.
When a radiologist finds something on a chest x-ray or a CT scan, he or she can't tell if it's cancer just based on looking at the scan.
They can give a pretty good guess, but by and large, they can't make the final diagnosis.
And you certainly cannot say where a cancer started based on a CT scan or a chest x-ray, correct?
Correct.
You can't diagnose lung cancer with radiology, right?
As I said, you can make a very, very good guess, but you can't make the final diagnosis.
Because pathology is the gold standard for diagnosing cancer.
Yes, it is.
And you have to have pathology slides with the tissue and pathology reports in order to determine the primary site, correct?
Yes, correct.
And there are staining tests that can be done on the pathology tissue to help determine where a cancer started, right?
Yes, so we can stain a tumor from the lung and tell whether it's primary lung cancer or breast or colon.
So you can actually do staining to differentiate tissue from being a lung primary versus a breast primary.
Correct.
And and other types of primaries as well, correct?
It would be a met, but yes.
Yes. Oh, and without staining, you cannot tell specifically, based on pathology, where a cancer started, right?
You need the staining.
And without staining, to determine the primary, you have to have information about what workup was done to see whether there's cancer in other parts of the body, right?
Correct.
Based on pathology, you can determine a cell type of cancer, right?
Yes.
And you mentioned adenocarcinoma, and that's a cell type of cancer, right?
Yes, it is.
And adenocarcinoma can start in the breast, colon, lung, pancreas, among other organs, correct?
Correct.
Adenocarcinoma can start outside the lung and spread to the lung, right?
Right.
The label adenocarcinoma itself does not mean that it started in the lung, correct? Now, there are occasions when there's a primary tumor that metastasizes to the lung, and the origin of the tumor is not known, right?
That is correct.
That's called cancer of unknown primary.
Yes,
And you've seen cancers of unknown primary in your practice.
I have.
There are a number of reasons in cancers of unknown primary for why it's difficult to detect the location of the primary, right?
Correct.
For example, the primary can be extraordinarily small and undetectable by radiology.
Yes.
Another situation where you may have cancer of unknown primary is if you have a patient where they just might not fully look for a primary, you're just treating for what you assume is the primary.
Yes.
You can find a single mass in someone's lung, and it can be from an unknown primary.
Yes, you can.
Cancer of unknown primaries are usually adenocarcinomas.
They are most often, yes.
And a lot of cancers of unknown primary are from the breast.
They are.
Now, back in the 1990s, there were tens of thousands of people every year that had cancer of unknown primary, correct?
Correct.
And generally speaking, because it's so common for any kind of cancer to spread to the lung, at least a good portion of those unknown primary cancers in the 1990s spread to the lung.
Correct.
So let's talk about Mrs. Adamson, okay?
Okay.
We don't have all the medical records from Mrs. Adamson's care and treatment, do we?
We don't.
In your words, there are a lot of important medical records missing in this case, right?
Yes.
We don't have any medical records or evidence documenting why the diagnosis of lung cancer was made, correct?
Correct.
There are only 43 pages of medical records available in this case, right?
Yes.
And in your experience and in what you've reviewed, knowing the course of typical cancer patients, you would expect there to be a lot more medical records available or had been created in a case like this,
I'm
right?
sure at some point there were a lot more medical records.
And once you saw the medical records available in this case, you actually asked plaintiff's counsel, are there more records available?
I did.
And you were told they didn't exist.
Yes.
And even the night before your deposition, you again asked plaintiff's counsel if any more records had become available in the case.
I did.
Out of the year and a half that Mrs. Adamson had cancer, we only have medical records from a 3-day period, 10 months after her diagnosis.
Correct.
We don't have any medical records that document the initial presentation of Mrs. Adamson when she was diagnosed with cancer, correct?
Correct.
We don't have any medical records showing the workup that was done, if there was any done, to investigate other possible primary sources.
Correct.
We don't have any medical records from an oncologist who treated Mrs. Adamson in Florida.
Correct.
You would agree that symptoms such as coughing up blood or chest pain could be evidence that somebody has lung cancer.
Yes.
At least from what we know from the medical information in this case, we don't have any reports of these typical symptoms of lung cancer, correct?
Correct.
So we talked about the importance of pathology in the diagnosis of cancer and in determining where the cancer started. But there are no pathology slides or reports available in this case, correct?
Correct.
And we have no information that any special staining was done on Mrs. Adamson's pathology tissue to determine the primary, right?
Correct.
There are no radiology films or reports available in this case, correct?
Correct.
And if the radiology films were available in this case, they would give us more information about Mrs. Adamson's cancer.
Well, we have radiology of her brain. We don't have radiology of her chest.
Well, we don't have any radiology films, correct?
That's correct.
And so there's some report in the medical records of some MRIs done on her brain, right?
That's right.
There's really no reports about what radiology showed in her lungs, correct?
That's correct.
And if we had that information, we would have more information about what the cancer looked like in Mrs. Adamson's chest, correct?
Correct.
We don't have any description of the size or specific location of the tumor in Mrs. Adamson's lung, right?
Only that it's in the right upper lobe.
But not that it's peripheral or centrally located or anything like that.
No.
Now, if somebody has primary lung cancer, the hilar and mediastinal lymph nodes in the chest are generally the first sites for that lung cancer to spread.
Correct. That would be the first evidence of metastatic disease.
Now here, we don't have any medical evidence that there was any spread to the hilar or mediastinal lymph nodes, correct?
Only that she was not operated on. So that implies that she was, quote, inoperable, which implies that it had spread.
We don't know where it had spread to, though, correct?
That's correct.
And nowhere in the medical records we have are the mediastinal or hilar lymph nodes mentioned.
No.
You mentioned your involvement in tumor boards. We have no medical record evidence in this case about whether Mrs. Adamson's case was reviewed by a tumor board.
No, we don't.
The only medical records available in this case are from Rhode Island Hospital.
That's correct.
You talked on direct about there being a few references to lung cancer in those records. We don't know where the doctors or nurses at Rhode Island got that information, do we?
We do not.
And there are no records from Mrs. Adamson's treating doctors in Florida among those 43 pages of medical records.
Correct.
And although there was a reference in one of the medical records to Dr. Spitz as the referring physician, we don't have any information as to whether the doctors at Rhode Island actually spoke to Dr. Spitz or with any of Mrs. Adamson's treating physicians, correct?
Correct.
It's possible that the history that's given in the medical records came directly from the patient or one of her family members.
That would be very unlikely, but possible.
Well, you saw Ms. Coughlin's testimony. You read her deposition where she's actually said she was the one who called up Rhode Island to help determine if her sister was a candidate for that treatment, right?
Yes.
Now, we don't have any information about whether Rhode Island Hospital looked at any pathology reports or tissue, correct?
It's not documented, but that's the routine.
But we don't have any actual medical record evidence here.
No.
And the only doctors we have medical records from at Rhode Island Hospital are a neurosurgeon and a radiation oncologist, right?
That's correct.
Now, neurosurgeons usually leave diagnosing lung cancer to medical oncologists like you.
Correct.
There's no mention of Mrs. Adamson seeing a medical oncologist at Rhode Island.
I don't believe she did.
A neurosurgeon, in your opinion, is not qualified to assess whether a person has lung cancer, primary lung cancer.
I don't like the term not qualified, but that's not in their area of expertise.
That's a better way to put it. So a neurosurgeon, for a neurosurgeon, diagnosing primary lung cancer is not within their area of expertise.
Correct.
And in your opinion, if a neurosurgeon is involved in the diagnosis of cancer, they would simply say there's a mass, biopsy it, and then just report what they see during the neurosurgery.
Correct.
The operative report you discussed on direct with the diagnosis of left occipital brain metastasis from the lung was signed by Dr. Walder, the neurosurgeon.
Correct.
Radiation oncologists can be qualified to diagnose cancer, but in this case, the radiation oncologist did not do that.
Correct.
There's no record here signed by the radiation oncologist that says lung cancer, correct?
That's correct.
Now, Mrs. Adamson went to Rhode Island Hospital for palliative treatment, right?
Correct.
That means that they were just trying to alleviate her symptoms, and they weren't, unfortunately, trying to cure her at that time.
That's right. They were trying to prevent further seizures.
In the 1990s, gamma knife treatment was not specific for lung cancer, right?
Correct.
Gamma knife treatment was available for anyone with brain metastasis.
Yes.
And it would not have mattered to Rhode Island Hospital what the primary source of Mrs. Adamson's cancer was in performing this gamma knife treatment.
Correct.
Based on your experience, the only thing that these doctors would have been worried about would have been the malignant tumor in the brain.
Correct.
The doctors at Rhode Island Hospital may not have looked at all at the primary site of Mrs. Adamson's cancer.
Correct.
Now, gamma knife technology was approved for use by the FDA in 1989.
Yes.
And so if it was approved by the FDA in 1989, you would agree that when Mrs. Adamson was getting gamma knife treatment in 1992, this form of gamma knife radiosurgery would have been out of the clinical trial phase.
Yes, it would.
We do not know where the doctors or nurses at Rhode Island Hospital who made the references to lung cancer got that information.
Got which information?
The references of lung cancer.
We don't.
And we do not have medical records showing that Rhode Island Hospital did any additional workup themselves to determine the source of Mrs. Adamson's cancer.
There's no evidence of that.
We do not have any medical records showing that Rhode Island Hospital did any tests to determine the primary source of her cancer.
Correct.
We do not have any medical records showing that Rhode Island Hospital made any kind of assessment of Mrs. Adamson's diagnosis.
Correct.
And it does not appear that Rhode Island Hospital ever made their own diagnosis of lung cancer, correct?
Correct.
Now, Mrs. Adamson passed away in September of 1993, correct?
Yes.
We don't have any records from the last 6 months of her life, right?
That's right.
You discussed the death certificate on direct, right?
Yes.
A death certificate alone does not answer the question of how someone died, right?
Correct.
When rendering an expert medical opinion in a case, you would not rely solely on a death certificate in determining the person's cause of death, correct?
It's just one piece of information, that's right.
And that's because a death certificate does not have enough information about the cause of a person's death.
Correct.
It's helpful for you to know when you're assessing the reliability of a death certificate what kind of expertise the person had that was filling out the death certificate.
That would be beneficial, yes.
And the accuracy of a death certificate is dependent on the information the person has that fills it out.
Yes.
We don't know what information the doctor who filled out Mrs. Adamson's death certificate had.
We don't.
And if the doctor who signed the death certificate was a hospice doctor, then you agree that she most likely did not do any additional workup or make an independent determination of whether Mrs. Adamson had lung cancer.
I'm sure he was just relying on the records.
Autopsies are the gold standard for determining the cause of a person's death, right?
Yes.
And autopsies are especially important in cancer cases where there's doubt about where the cancer started, because they can provide medical evidence about where cancer starts.
Yes.
And it's possible that during an autopsy, you discover a different primary site of cancer than what the original treating physician believed.
There's a small possibility, yes.
Well, you're aware of that happening, right?
Yes.
You're being bored. It's okay. I don't have to go. Thank you. Thanks. things. Thank you. Sorry. Now, Mrs. Adamson was only 40 years old when she was diagnosed with cancer in May of 1992.
Correct.
Most smokers who develop lung cancer do not develop lung cancer until their 6th or 7th decade of life, right?
That's correct.
And the mean age for lung cancer is probably 60 years old.
Correct.
That's
But it's
all-
the same for all tumors that we're discussing, breast and colon as well.
Well, the mean age for lung cancer being 60 years old, that's 20 years older than what Mrs. Adamson was when she was diagnosed, right?
That's right.
And we're going to talk about breast cancer at age 40 in a minute. But just sticking with lung cancer for the moment, you agree that 40 years old is very young to being diagnosed with primary lung cancer.
Yes, it is.
And 40 years old is especially young for a female to be diagnosed with lung cancer.
Yes. 40 years old is very young for almost all cancers. You're basically protected at 40.
Now, you said that a 40-year-old woman getting lung cancer is exceedingly rare, right?
Correct.
You saw in the medical records, well, you actually talked about on Direct about this condition of hidradenitis, right?
Correct.
And Mrs. Adamson had. And you agree that Mrs. Adamson's history of hydradenitis put her at an increased risk for the development of cancer.
It puts her at less than 1% risk of development of squamous cell skin cancer.
But you agree that hydradenitis can be a precursor to cancer, right?
Squamous cell skin cancer, yes.
But then you talked about the scar tissue that would have occurred from the the treatment for the hydradenitis, right?
Well, it's not the scar tissue, it's the inflammation in the lymph nodes that leads to the potential for the development of cancer.
But setting that aside and looking at just the scar tissue is a potential for tumor origin.
No. It's not the scar tissue. It's the inflammation that forms the scar tissue.
Okay. Well, adenocarcinoma historically or pathologically often arises in scar tissue.
It often arises at sites of inflammation. For example, you can have a granuloma in the lung that's inflamed that gives you lung cancer.
And adenocarcinoma may arise from scar tissue in the breast, correct?
From inflammation in the breast.
Additionally, the presence of inflammation in scar tissue might hinder the ability to see a tumor with radiology.
It might.
Now, there are a number of primary cancers other than lung that you cannot rule out in this case, right?
Correct.
You talked on Direct about your differential diagnosis in this case, right?
Yes.
And you said that the percentage of likelihood of breast cancer in this case is 40%.
Correct.
And the percentage of likelihood of colon cancer in this case is 20%.
Correct.
Can I get my easel here? May I approach her?
Sure, of course, absolutely.
You agree that Mrs. Adamson was at a high risk for breast cancer, correct?
She was at an increased risk for breast cancer.
And you've actually said that Mrs. Adamson was at a high risk of breast cancer and that it's possible that breast cancer, that this could have been breast cancer that was missed.
Okay, so if you balance it with smoking, the overwhelming risk is due to smoking and lung cancer. But yes, she also has a much smaller risk of developing breast cancer.
Okay, but you acknowledge that you've said she's at a high risk for breast cancer.
Correct.
And you agree that it's possible she has a tumor that was missed in her breast, correct?
That's a remote possibility.
All right. Well, let's talk about that possibility. One reason that you agree that it's a possibility that this was a breast cancer that was missed is because of the cell type adenocarcinoma, correct?
That's correct.
Most breast cancers are adenocarcinoma.
They are.
May I approach you?
Sure.
Without doing staining on the pathology tissue, there's no way to differentiate between breast adenocarcinoma and lung adenocarcinoma.
That is correct.
So the pathologist, as far as we know, looking at the pathology, would not have been able to determine whether this was breast adenocarcinoma or lung adenocarcinoma if they did not do any staining.
They would need the stains to make that diagnosis.
And again, we have no medical evidence staining was ever done.
Well, I'm sure it was done, but we have no evidence.
Okay, well, you're not even sure what stains were available in 1992 to differentiate between lung cancer and breast cancer.
1992 is not that long ago.
All right, but you being a
Maybe
pathologist...
for you it was.
Well, you being a pathologist, you're not sure of the specific stains available at the time.
The stains that were used are very similar to what's used today. What's different today is we now do gene studies, which were not done in the 90s.
We have no information here that the doctors ever did any stainings that would tell the difference between breast or lung adenocarcinoma.
That's correct.
Breast cancer can be widely metastatic and spread to the lung, perineal area, and the brain, correct?
It can.
You have found a mass in someone's lung and later determined that it came from the breast.
Correct.
Yes, of course.
A lot of pressure writing. Just make sure you're spelling. Another reason that Mrs. Adamson was at a high risk for breast cancer is because she was the appropriate age for breast cancer, correct?
No, that's not correct. So, as I said, in your 40s, the only tumor you're at risk for, a higher risk for, is melanoma. You're not at risk for lung or for breast or for colon cancer. All of those are tumors of individuals 55 and older.
Okay, well, let's look at your deposition. Yeah. 205, 2 through 8. You remember giving a deposition in this case?
Yep.
Your Honor, may I approach?
Yes, of course.
Here you go, Dr. Roser. And I'd ask you to turn to page 205, lines 2 through 8. And just let me know when you get there. You there?
Yeah, I'm here.
In your deposition, you were asked the following question and gave the following answer. Question. What makes you think that breast is a possibility in this case? Answer. Well, she's at the appropriate age. She's at a high risk.
Appropriate age is what I said.
Okay, well, let me just read it and then you can tell me if I read it correctly, okay? Answer. Well, she's at the appropriate age. She's at a high risk for breast cancer. There's no evidence that she had breast cancer. However, it's possible that she has a tumor that was missed and it's adenocarcinoma. Did I read that correctly?
You did. So there's evidence that there's a report that a sister had breast cancer at a younger age. That's why she's at an appropriate age for the development of breast cancer. But that's not what you asked me before. You asked me about whether breast cancer occurs at that age. And as I said, all of these tumors tend to be in the 50s and 60s. Now, in her case, she does have an increased risk because of her family history.
And her age, right?
Well, she's old enough is the way I would put it. She's not at the peak age for development of breast cancer.
Okay, well, let's look at the statistics then. You're familiar with the SEER Cancer Statistics Review, correct?
Correct.
And these statistics are put out by the National Cancer Institute, right?
Correct.
You agree that the SEER cancer statistics are reliable?
Yes.
The SEER data for all cancers in women aged 40 to 44 shows that primary lung cancer was only 4% of those cancers, right?
Correct.
Breaking that down further, only 3.7% of cancer in women ages 40 to 44 was non-small cell lung cancer, which would include adenocarcinoma, correct?
Correct.
Now, based on the SEER data between 1990 and 1994, almost 50% of the cancer that women aged 40 to 44 got was breast cancer.
Correct.
And between 1990 and 1994, a 40-year-old female was 10 times more likely to have breast cancer than lung cancer.
Okay, let me stop you right there. So I will agree completely that at birth, she is much more likely to develop breast cancer than she is to develop lung cancer. However, because of her smoking history, when she does develop a lung mass, there is an 80% chance that that's lung cancer, not breast cancer.
Your Honor, respectfully move to strike as non-responsive.
Sustain.
Dr. Roser, a 40-year-old female was 10 times more likely to have breast cancer than lung cancer between 1990 and 1994, correct?
A 40-year-old female at birth is predicted at 40 to be tenfold more likely to develop breast cancer than lung cancer before they start smoking.
Okay, well, move to strike as non-responsive, Your Honor.
Sustain.
Starting at before.
Sure.
Dr. Roser, when we're looking at the SEER data, what the SEER data shows is just the incidence of different types of cancers at that time, right?
For all individuals, male, females, smokers and non-smokers as well, and therefore the data are inaccurate for a smoker.
Okay, well, the SEER data actually includes smokers, right?
It does, but it also includes non-smokers.
And so it's just looking at the incidence rate, not the relative risk, correct?
It's looking at the incidence rate.
So what the SEER data does is it looks at all the people in the country and says how many people got a specific type of cancer, right?
Correct.
So that's what we're looking at here, right?
That's what you're looking at, yes.
Okay. So between 1990 and 1994, when looking at the incidence rate, 13.9 times more 40-year-old females got breast cancer than non-small cell lung cancer, including adenocarcinoma, correct?
Correct, but in order to be accurate, you have to look at those who smoked and those who didn't.
All right, move to strike as non-responsive.
Just
To be accurate. All I'm asking is about the incidence. The incidence includes smokers and non-smokers.
Correct.
And
That I will agree with.
When looking at both, 13.9 times the number of 40-year-old females got breast cancer than lung cancer in 1990 to 1994.
Correct.
Now let's talk about the family history you brought up, okay?
Okay.
Mrs. Adamson's sister, Sue Knutson, had breast cancer in her 40s, right?
That's what's written in the depots.
And having a sister who gets breast cancer in her 40s doubles a person's risk for breast cancer.
That's correct.
Mrs. Adamson was at double the risk for developing breast cancer compared to other women, correct?
Correct. But that's a lifetime risk.
Yes, of course.
Now, we heard a little bit about BRCA gene testing. The BRCA gene only accounts for 10% of breast cancers, correct?
That's correct.
The fact that somebody is BRCA gene negative does not rule out a genetic predisposition to breast cancer.
That's correct.
And Ms. Knudsen got breast cancer even though she was BRCA gene negative, at least from the information we have.
Correct.
And Ms. Knudsen being BRCA gene negative does not rule out the possibility that her sister could have developed breast cancer.
Correct.
The gold standard for investigating whether someone has a breast tumor is a diagnostic mammogram, right?
Correct.
You could also do a breast MRI.
Yes.
You usually follow that by an ultrasound and then a needle biopsy, right?
Right.
There's no evidence in this case that a diagnostic mammogram or a breast MRI was ever done.
Correct.
A CT of the chest would not rule out a lesion in the breast, correct?
Correct.
We don't have any medical records in this case that would evidence that Mrs. Adamson's doctors did any work that would rule out breast cancer.
Well, a CT won't rule it out 100%, but a CT, more likely than not, would show it if it existed.
Well, chest CTs do not always show a lesion in the breast, correct?
Nor do mammograms or MRIs.
Okay, so a chest CT could miss a breast cancer, right?
Any test can miss a breast cancer.
And it's not the technique of choice to use to determine breast cancer, right?
Correct.
To find a breast cancer, right?
Right.
We talked about diagnostic mammograms, so the gold standard, right?
They can miss it as well.
So would you agree then we do not have any medical records in this case that would evidence that Mrs. Adamson's doctors did any work that would rule out breast cancer?
Correct.
May I approach?
Yes, of course.
And even if Mrs. Adamson's doctors did in fact work her up for breast cancer, you would agree that breast cancer is difficult to screen for.
Difficult to what?
Screen for.
Screen for?
Or identify.
It may not be identified, yes.
It's particularly difficult to identify in individuals who have dense breasts.
Correct.
And in those women, the tumor may not be apparent.
That's correct.
Breast cancer is difficult to find in women with a higher BMI due to their breast density and size, correct?
That's correct.
Mrs. Adamson had a high BMI from the information we have.
She did.
And Mrs. Adamson's high BMI put her at an increased risk for breast cancer.
Correct.
It also put her at an increased risk for any workup missing breast cancer.
Correct.
Your Honor, may I approach?
Sure, of course.
Let's turn now to your opinion that Mrs. Adamson had lung cancer caused by smoking. You do not consider yourself an expert in smoking causation.
I do not.
You've never published any peer-reviewed literature on smoking causation.
No.
And you've never testified as an expert witness in any other case about smoking causing cancer.
No.
So let's look at the facts about lung cancer and smoking. Not all smokers get lung cancer.
That's correct.
Millions and millions of smokers never develop lung cancer.
Correct.
Millions and millions of smokers develop cancer unrelated to their smoking.
Correct.
In your opinion, smokers have about a 20% chance of developing lung cancer.
That's correct.
So 80% of smokers will not develop lung cancer.
Correct.
Just because someone smokes and gets lung cancer, it does not mean that his or her lung cancer was caused by smoking.
No, if someone smokes and gets lung cancer, 80% of the time that's due to the smoking.
And 20% of the time it's not.
No, you're mixing it up. 20% of those who smoke get lung cancer.
Okay.
80% do not get lung cancer. However, if you smoke and get lung cancer, 80% of the time, the smoking caused it.
Got it. The label adenocarcinoma does not mean that smoking caused the cancer.
Correct.
And a portion of patients who are never smokers get adenocarcinoma of the lung.
They do.
Adenocarcinoma can occur in organs that you would say smoking did not cause that.
Correct.
And smokers can develop adenocarcinoma in organs other than the lung that are not related to smoking.
Yes.
And we don't have any medical records indicating that Mrs. Adamson's doctors determined that her cancer was caused by smoking.
We do not.
You're basing your opinion in this case that Mrs. Adamson's cancer was caused by smoking on statistics.
Correct.
You have no other basis for that opinion.
That's correct.
Hold on. Sorry, thank you. Now, genes and family history are independent risk factors for cancer apart from smoking.
Yes, they are.
Genes play an important role in cancer no matter what.
Correct.
And the younger a person is who develops cancer, the stronger the contribution of their genetics plays in that cancer.
Well, what I would say to that is more likely the genes are playing an important role if it occurs at a younger age.
Now, because of Mrs. Adamson's young age and how unusual or exceedingly rare, in your words, it is for a woman that age to develop lung cancer, you cannot rule out the possibility that Mrs. Adamson developed cancer solely based on her genetic predisposition.
It's exceedingly rare for a non-smoker of that age.
Well, take a look at your deposition there on page 211, 5 through 8. Let me know when you're there, Dr. Roser. You there? You were asked the following question and you gave the following answer. And can you rule out...
Let me finish reading.
Oh, sorry.
Go ahead.
Okay. You were asked the following. I'm only going to ask you one question after I finish reading this, and that'll be, did I read that correctly? Question, and can you rule out the possibility that Mrs. Adamson developed cancer based solely on her genetic predisposition? Answer, I can't rule that out. Did I read that correctly?
You did. Keep going.
Did I read that correctly, Dr.
You did, so keep going.
Okay, well, did I
And
read
the
that
fact that
correctly?
Mrs. Adamson got cancer so young makes it more likely that it's related to genetic predisposition. My answer, well, you can have two risk factors, and although they're independent, they are still additive. So my point is that she may have a genetic risk, but the smoking is the overwhelming cause of the lung cancer.
Okay, but I did read it correctly that you could not rule out the possibility here that Mrs. Adamson developed her cancer based solely on her genetic predisposition,
And
correct?
I responded that there are two independent risk factors.
All right, move to strike as non-responsive.
Sustain.
For my next set of questions, my questions are based on the assumption that smoking did cause Mrs. Adamson to develop a lung cancer. The development of lung cancer is a multi-year process, right?
It is.
And Mrs. Adamson had stage 4 cancer by at least the end of 1992.
Correct.
For non-small cell tumors, including adenocarcinoma, more likely than not, they are present for 7 to 10 years before they reach a diagnosable clinical size.
They're present as premalignant lesions, yes.
And for adenocarcinoma specifically, it takes about 7 to 10 years for the first cancer cell to progress to the amount of cancer cells to form stage 4 cancer.
Correct.
And you would agree that any smoking done after a person has certain premalignant conditions would not contribute to causing the cancer.
It tends to add to the cause.
But not directly cause, right?
Well, I don't know what directly cause means. The smoking prior to the development of the invasive cancer plays a role, and the smoking after that also plays a role.
Well, any smoking done after a cancer has become invasive cancer would not have contributed to the development of the cancer, correct?
Once the cancer is invasive, it's malignant.
Okay. And for adenocarcinoma specifically, a little bit of exposure early on sets you on the road if you're going to get lung cancer from smoking.
It does.
There's a point in time when you smoke enough cigarettes that if you're going to get lung cancer from smoking, then the stage is set and you're going to get lung cancer from smoking regardless of whether you continue to smoke.
Stopping has some bearing, but by and large, that's a correct statement.
Once the stage was set for Mrs. Adamson to develop lung cancer, quitting smoking was not likely to have much of an impact.
That's correct.
Any continued smoking that Mrs. Adamson did from the mid-'80s to 1992, in your opinion, more likely than not, did not have an impact on whether she died from cancer.
That's not quite what I said.
All right, well, let's look at page 240, lines 15 through 19. Just let me know when you're there. You were asked the following question and you gave the following answer. Question, okay, so any continued smoking that Miss Adamson did between or from the mid-'80s to 1992 or 1993, in your opinion, more likely than not, did not have an impact on whether she died from cancer. Answer, correct. Did I read that correctly?
You did. And go further.
Your Honor, under the rule of completeness, I would ask that page 241, lines 4 through 19 be read.
Okay, sure.
So you can't pick and choose which lines.
That's my job, Doctor, not yours. Thank you very much. Actually, you know what? Let's take a break. Let's take a quick 5 minutes.